for standing by. At this time, all participants are in a listen-only mode. During the discussion, we will conduct the question-and-answer session. To ask a question, you may press star followed by the number 1. This call is being recorded. If you have any objections, you may disconnect at this point. I'll turn the meeting over to your host, Jana Petchak. You may begin.
All right, Rose. You all today to our quarterly North Dakota Mission Lifeline stroke webinar. Our topic for this afternoon is going to be IV alteplase. Here, I'm going to advance the slide. All right, just very quickly, for anybody who is new to the Mission Lifeline initiative, wanted to base briefly on what Mission Lifeline is. Mission Lifeline is an American Association initiative to improve the care of patients suffering from time-sensitive diagnoses. Pre-myocardial infarction has been the point of interest, and we are the first state in the nation now to be doing Mission Lifeline stroke. To really reduce any barriers that could cause delays in care and also improve efficiencies within each part of the system that cares for patients suffering from a stroke, going even raising public awareness all the way to emergency department, radiology, laboratory, vascular lab, critical care units, and rehabilitation. So of course, one of the purposes of our program is to focus on the system rather than the individual so that feedback can be gathered to improve quality of care for stroke patients. Brief description of our Mission Lifeline project. We are in year 1, and we have a 3 that we have to really build upon the great system that does already exist here in North Dakota, and to with our Department of Health and other key players in making improvements that we can. So, as far as care of stroke patients is concerned, IV TPA is currently still the gold standard of care for patients who are eligible to receive this. To share some data here in North Dakota, this first slide shows individuals across the state. This is hospitals, so it includes both tertiary centers and critical access hospitals, who were able to receive TPA within a 3-hour window. And back, you can see in Q1 of 2017, we were at 71.4%. We were at 72%. In Q3, 80%. So climbing and going the right direction. Clearly, we'd want that number to be much closer to 100% for all those patients who were eligible, that they receiving alteplase therapy and the best chance for a good outcome and recovery. Data. This slide shows data from our critical access hospitals specifically. And the numbers here are very small, so it does not take much to really throw your percentage points off. But Q1, 2 out of the 6 patients who were eligible received TPA treatment, putting us at 33.3%. Q2, we were at 57.1%. And in Q3, we had 2 patients entered into the registry that were eligible for the therapy, and all of them received putting us at 50%. The critical access hospitals struggle with it. They don't have the resources and the stroke team to help with getting that TPA registered as quickly. So there are certainly want to be helping critical access hospitals overcome the unique challenges that they face. Michael will tell you here shortly, there are a certain amount of people who are eligible to receive TPA out to the 4.5-hour window. And this slide takes into consideration those patients. And this one, again, is looking at the critical access hospitals specifically. So larger numbers that we're dealing with for this group. But again, we are still looking out right around that 50% mark for patients who, from all I can tell by looking at their charts, could have gotten that treatment within the 4.5 hours. As you can see, that perhaps 50% of those patients did not receive the therapy that they could have. So now I'll turn things over to Michael Peterson, and I'll let him introduce himself to all of you, tell a little bit about his background, and he's going to do a talk here on IV alteplase for acute ischemic stroke. Right, turn over to you, Michael.
Okay, thank you, Anna. As said, my name is Mike Peterson. I am a pharmacist at Trinity Hospital in Minot. I graduated from NDSU in 2010, and I have worked at Trinity ever since as a pharmacist in the hospital. I work not only in the central pharmacy dispensing medications, but also as a decentralized pharmacist out on various units providing clinical services. I've interacted with stroke patients in the ICU, on our stroke unit, ER, and even in the rehab setting. So I'm also our institution's pharmacist representative on our stroke committee. Okay, we'll start. Like Jana said, my presentation.
I have to control the slide here. We were having some technical issues.
Yeah, just came through. Let's see if it works. So we'll talk about IV alteplase today for acute ischemic stroke. There we go. So my objectives for today: overview of IV alteplase therapy for acute ischemic stroke. We'll pair alteplase with tenecteplase. Highlights from the new 2018 acute ischemic stroke guidelines in reference to IV thrombolytic therapy. We'll discuss safety issues when ordering IV alteplase. Also do a quick review of how to mix and administer alteplase in the setting of acute ischemic stroke. First, what is TPA, or tissue plasminogen activator? Tissue plasminogen activator is an enzyme in our bodies. You know, it's a natural physiologic thing. Binds to fibrin components, or the fibrin components of a thrombus or a blood clot, and catalyzes that conversion of plasminogen to plasmin. Plasmin is that product then that breaks down or lyses the fibrin clot, fibrin degradation products. You give IV alteplase or any IV tissue plasminogen activator, you essentially accelerate that conversion of plasminogen to plasmin, accelerate the breakdown of that fibrin clot. You'll notice there are the red arrows, and those are inhibitors of both TPA and plasmin that work normally to prevent, you know, the regulatory mechanisms to prevent fibrin degradation in our bloodstream. When we give something like IV alteplase, that system is completely overwhelmed, and that's why we do get the widespread breakdown of those clots. Medications. Current alteplase or activase and tenecteplase or TNKs are biosynthetic forms of human TPA produced by recombinant DNA technology that are available on the market. Are other thrombolytic agents that have been studied or used in the past, but they are not currently available in the U.S. Incletoplase, desmotoplase, urokinase, and streptokinase. The guidelines say these are not recommended to be used for acute ischemic stroke outside of clinical trials. Alteplase or activase is the only FDA-approved thrombolytic for acute ischemic stroke at this time. It has FDA approval for acute MI and pulmonary embolism. Dosing acute ischemic stroke, you give a total dose of 0.9 milligrams per kilogram up to a maximum of 90 milligrams total. Patients less than or equal to 100 kilograms, you give a loading dose of 0.09 milligrams per kilogram with 10% of your total dose as a bolus over 1 minute, followed by the remaining 0.81 milligrams per kilogram, or 90% of that dose, as an infusion over 60 minutes. That gets easier in patients greater than 100 milligrams because you load with 9 milligrams, followed by 81 milligrams as an infusion over 60 minutes. That's 10% and 90% of that 90 milligrams, respectively. Or TNKs, this time does not have an FDA-approved indication for acute ischemic stroke. The medication that does is alteplase. Currently, tenecteplase is only indicated for acute myocardial infarction. Tenecteplase is very similar to alteplase. It's a 3-point mutated variant of alteplase that is manually engineered to have 3 advantages over alteplase: long half-life, higher fibrin specificity, and an increased resistance to plasminogen activator inhibitor 1. The thing acknowledged by our current guidelines is a 0.4 milligram per kilogram dose administered as a single IV bolus. So capped that have been done have capped that at 40 milligrams, which is lower than the current cap of 50 milligrams per stroke, or per MI, so the dose is lower for stroke. The one I'll point out about this dosing with the single IV bolus, that's because of the long half-life it has compared to Alteplase. Alteplase has a half-life of 20 to 24 minutes initially, which Alteplase's half-life of 5 minutes. So it takes much longer for your body to metabolize the place. That's why we don't need to give the continued infusion after that initial bolus. That's the difference in the dosing. That's the difference in that dosing. There's been 3 phase 2 and 1 phase 3 trials that have compared IV tenecteplase to IV Alteplase. At this time, tenecteplase has not been proven to be superior or inferior to Alteplase. Alteplase still has much more evidence to support its use. The 2018 guidelines, based on the 1 phase 3 study out there, did state tenecteplase might be considered as an alternative to Alteplase in patients with minor neurological impairment and no intracranial inclusion. That is the 1 phase 3 study. The one limitation of it is the median NIH stroke scale score was 4. These patients in general had very mild stroke. For that reason, that's one of the limitations why they can't really expand that recommendation beyond mild stroke. So states tenecteplase appears to be safe, but unclear at this time whether it is as effective or more effective than Alteplase. So right now with tenecteplase, there just isn't the evidence to support its use like there is Alteplase. Alteplase has that FDA approval. That would be, that is by far and away the standard of care, and the recommendation to use acute ischemic stroke is Alteplase. Because by the nature of how it works, we'll kind of review some warnings and precautions. The biggest risk with this medication you'd expect is bleeding. It can cause significant, sometimes fatal, internal or external bleeding. Some precautions to take in patients who have received IV Alteplase in the previous 24 hours. Avoid intramuscular injections or any trauma. Perform venous punctures and finger sticks very carefully and only as required. If possible, it would be recommended to draw that blood out of a line. If a patient has a line you can get blood out of. If you need to do finger sticks in a brittle diabetic or get other venous punctures for any reason, be very cautious and apply pressure after you've done so. Avoid the internal jugular and subclavian veins when you're doing that, as those vessels are not compressible. Arterial puncture is necessary for any reason. Use an upper extremity vessel that is accessible for manual compression, pressure for at least 30 minutes, and monitor that carefully. Other warnings, things that has been seen, oral lingual angioedema has been observed during Alteplase infusions and for up to 2 hours after the infusion. In these cases, patients were on concomitant ACE inhibitors such as lisinopril, allopril, things like that. So especially patients want to monitor during and for several hours after the infusion. A warning for cholesterol embolization, which is rare, and because that coagulation tests may be unreliable during Alteplase therapy. All the other adverse reactions, the package insert just does include some of the information from the original trials that did show a higher incidence of intracranial hemorrhage in stroke patients when compared with placebo. All post-marketing experience does indicate or have shown that cerebral edema, cerebral herniation, seizure, and strokes are possible after this medication has been given. If you would have a patient that did develop intrableeding, I'm going to do the guidelines for management of symptomatic intracranial bleeding that does occur within 24 hours after administration of IV Alteplase. Just people are familiar with it. Recommendations are, if the infusion is still going, to stop Alteplase infusion, CBC, PT, INR, APTT, fibrinogen level, and also do type and cross match. I'm going to do an emergent, non-enhanced head CT to evaluate to see if there's a bleed and the extent of it. and then you want to give cryoprecipitate and tranexamic acid or aminocaproic acid. At this, it's appropriate to get hematology and neurosurgery involved in the case, and supportive therapy to the patient as indicated. We will talk about abbreviations and some recommendations from ISMP to improve safety when ordering Alteplase. ISMP does report instances of patients receiving the wrong medication when abbreviations TPA and TNK are used. These are likely due to the medications being used in similar settings and patient populations. They're both used in patients with cardiovascular disease. Alteplase or TNK administered a dose intended for Alteplase or Activase will result in a significant overdose. That if you would give Tenecteplase at recommended dose for Alteplase, it would be a little over a twofold overdose. Could result in significant overdose and risk for bleeding, extended hospitalization, or death. K and TNK are both listed on the drug name abbreviation section on ISMP's list of error-prone abbreviation symbols and dose designations. The recommendations never use abbreviations for drug names. Do not use the abbreviation TPA, and we do refer to these agents. Refer to them both by their brand name, established generic name, or both in all verbal and written communication. So the recommendation would be to write Activase out, Alteplase out, or write both of those out. Do not use TNK as an abbreviation for TNKs. That's been confused with TPA. Remove TPA and TNK from all standard order sets. TPA entry screens and treatment protocols. Tenecteplase, but not Tenecteplase, is approved for use in acute ischemic stroke and coronary embolism. Recommendation is prescribers should state the indication on the prescription or order or use appropriate order sets to help ensure the correct drug is ordered and dispensed. Consider use of alerts in electronic order systems or EM cabinets. Other recommendations or things I've heard of people doing is doing a timeout prior to the administration of either Alteplase or Tenecteplase with us of the team to discuss what it's being given for, what medication, what drug. And I'll discuss some other recommendations they've done in their facilities later. 2018 stroke guidelines. These are hot off the press. They came out just over 2 weeks ago. Had a chance to review them some, but not extensively, but I'll just go through some of the highlights. These are far from all-inclusive. There are many more recommendations. To grab some of the highlights that involve IV Alteplase administration. One of the changes is involving expand the window for mechanical thrombectomy in ischemic stroke patients from 6 to 24 hours. So were some changes involving the Alteplase administration as well. I've put an LS in a brain. You'll notice time of the essence to those brain cells, and sooner IV Alteplase can safely be given, the outcomes that have been seen. The first recommendation we'll talk about that you'll see is kind of going there is door to needle. It's recommended that door to needle time goals be established at all facilities with the primary goal of achieving door to needle times within 60 minutes in 1% or more of acute ischemic stroke patients treated with IV Alteplase. A secondary goal, the evidence isn't as strong for this, but it is a consensus recommendation or expert opinion. It's reasonable to establish a secondary goal of achieving door-to-needle times within 45 minutes on 50% or more of these patients. So they're looking to push that door-to-needle time down a little bit. All patients admitted to the hospital with suspected acute stroke should receive brain imaging evaluation on arrival. In most cases, non-contrast CT will process their information to make decisions about acute management. Systems should be established so brain imaging studies can be performed within 20 minutes of arrival to the ED in 50% of those patients who may be candidates for IV Alteplase or mechanical thrombectomy or both. Other tests The test that they recommend, or other diagnostic test that must precede initiation of IV alteplase in all patients, is a blood glucose. The reason for that is hypoglycemia, especially also hyperglycemia, mimic stroke. So prevent giving IV alteplase for a neurological condition, vascular condition, I should say. They recommend waiting until that result is back. There are other tests that may be necessary in some circumstances. For example, if you do have suspicion of either thrombocytopenia or coagulopathy based on past medical history or medications they're taking, IR, APTT, and platelet count would also be appropriate to wait for results for in those situations. EC assessment is recommended, but should not delay initiation of IV alteplase. Troponin assessment is recommended. Emphasize do not delay initiation. Chest X-rays are recommended. Our usefulness of chest X-rays in setting in the absence of pulmonary, cardiac, or pulmonary vascular disease is unclear. If obtained, they should not unnecessarily delay administration of IV alteplase. Patients who do have elevated blood pressure and are otherwise eligible for treatment with IV alteplase should have blood pressure carefully lowered so their systolic blood pressure is less than 185 and their diastolic is less than 110. Just to review a few options to treat arterial hypertension recommended in the guidelines. Labetalol, nicotine, and clofazimine were the recommended guidelines. I do realize that some hospitals may not have nicardipine or clofazimine available. It's recommended other agents such as hydralazine, or enalapril may also be considered in those cases. If the blood pressure is not able to be maintained less than 185 over 110, do not administer alteplase in those situations. Now, blood pressure during and after alteplase therapy, you should maintain that blood pressure less than 180 over 105. During and up to 2 hours after the start of alteplase therapy, the recommendation is to monitor blood pressure every 15 minutes for the first 2 hours after initiation, then every 30 minutes for 6 hours, and every hour after for the last 16 hours of that first 24. If systolic blood pressure during that time is greater than 180 up to 230, diastolic is greater than 105 up to 120. Labetalol, like we talked about before, but they do recommend in this case potentially a continuous infusion. The nicotine or clofazimine infusions, like we talked about before. And blood pressure is not controlled or diastolic is greater than 140. In case they do recommend considering sodium presside. The indications of the Class 1 recommendations have the strongest benefit to risk ratio, or the benefit is greater than the risk, with the highest amount of evidence to support it. So these are clear-cut indications for stroke. 3 hours, it's equally recommended for patients less than 80 or greater than 80 in that first 3 hours. It doesn't matter. So symptoms are recommended despite there being an increased risk of hemorrhagic transformation in those patients with severe symptoms. Disabling stroke symptoms, they also recommend to treat that in these patients. With an extended 3 to 4.5 hour window, this recommendation is still for people under age 80 or up to age 80 without a history of both diabetes or prior stroke. NI stroke scale score was less than or equal to 25, non-oral anticoagulants, and patients without imaging evidence of ischemic injury involving more than 1/3 of the MCA territory. Patient urgency, they emphasize, as quickly as possible within the above timeframes for those patients. Time to treatment is strongly associated with outcomes. Blood pressure, as long as it can stay be lowered to less than 185 over 100, or 110, I believe that's a typo. Blood glucose, initial glucose levels greater than 50 milligrams per deciliter. We talked about the importance of having that blood glucose back. Ischemic changes on CT of mild to moderate extent other than frank hypodensity. So those patients have that evidence you'd want to give. Prior platelet therapy, if patients are currently on monotherapy or combination therapy, so aspirin or aspirin Plavix, you continue, there's restriction there, you would continue to give. It is indicated. And renal disease patients, as long as APTT is normal, they're indicated to receive it as well. Contraindications, these situations where the benefit is either equal to the risk or the risk is greater than the benefit. So any of these things would be contraindication that you would not give alteplase in those situations. Under time or unwitnessed symptom onset, the last known time to be at baseline is greater than the 3 or 4.5 hours, depending which criteria they meet. CT is either acute intracranial hemorrhage or extensive regions of clear hypoattenuation. Prior ischemic stroke, head trauma, or intracranial or intraspinal surgery within the previous 3 months. Of intracranial hemorrhage, and patient presenting with signs and symptoms most consistent with subarachnoid hemorrhage. Also bleed or malignancy within 21 days. If they're less than 100,000, INR is greater than 1.7, APT is greater than 40 seconds, or PT is greater than 15 seconds. IV alteplase is contraindicated if any of these apply. However, if you do not suspect the patient has a coagulopathy, patient has no history of thrombocytopenia, not on an anticoagulant, you do not have to wait for these lab results. You can start IV alteplase if suspicion is low for coagulopathy. If a result would come back, say the INR would come back greater than 2, at that point you would stop the infusion. You can initiate this infusion patients with low suspicion prior to seeing these results. Common inhibitors or direct factor 10A inhibitors are indication, and appropriate lab assays are normal. Not all facilities are able to do these assays right now. So essentially, if they've received a dose in the last 48 hours, assuming no renal function, would be contraindicated. Patients who receive low molecular weight heparin or enoxaparin within 24 hours, contraindicated. Others would be infective endocarditis, aortic arch dissection, and axial intracranial neoplasm. Recommendations that are a Class 2 recommendation. The benefit is greater than the risk in motions, but the evidence is not as strong. The recommendation isn't as strong. The recommendation is to extend that 3-hour window to half hours for patients greater than 80 years old. Safe and can be as effective as in younger patients. Patients taking warfarin, but the INR is less than 1.7, it appears safe to go out to 2.5 hours and may be beneficial. Also, with prior stroke and diabetes, may be effective as a treatment in that 0 to 3 hour window, so it may be a reasonable option. In that 0 to 3 hour window, stroke symptoms that are judged as non-disabling may be considered at this point. With that, because the symptoms are mild, you must weigh the risks out, or weigh risks with the possible benefits. Mild stroke, it's like that window can be extended out beyond that 0 to 3 hour window. Maybe a reasonable option, weigh risk versus benefits as always. Early movement. IV alteplase is reasonable for patients who present with moderate to severe ischemic stroke and demonstrate early improvement but remain moderately impaired and potentially disabled. The recommendation is to still give it in patients who have improved but still do have some symptoms. Additional recommendation, the chart that's in the guidelines is pretty extensive. It covers a number of conditions. There was I could go to all of them to look through and be familiar with those. I'll recommend, being in touch in these cases, discuss with a neurologist in that final decision making. Post-thrombectomy, patients eligible for IV alteplase should receive it even if they are considering doing endovascular therapies. So in patients undergoing consideration for that, you not observe those patients for response after giving IV alteplase, and you would move them on, get them to the next area where they could assess and perform that intervention. Really quickly run through constitution and administration of Alteplase. When you open the Activase, I'll call it Activase from here because I did use, the vials are Activase. When you first open the box, the vial of Activase, the vial of sterile water, and the transfer pin. I also recommend getting a couple more syringes, one to drop the bolus dose into, and the other one of the excess. Oh, excuse me 1 second. Okay, about that. At this time, it probably is a good idea to get your IV sets as well. So the first, remove those vial tops, get open, swab those vials with alcohol swabs to reduce the risk of contamination at that point. At this, I want to remove one of the protective caps from the transfer device. Sterile water just sitting vertically, and insert into the center of the stopper of the sterile water for injection vial. You let the sterile water vial first and go, there's a ring in the center of that vial where you'd want to go into. Keep the vial upright. You'll want to insert the Alteplase vial on the other end of the pin. So keep the vial, stand upright, hold the Activase vial upside down, position so the center of the stopper is directly over the pin. Push down onto the transfer device and check the piercing pin is inserted through the center of the Activase vial stopper. You'll want to invert those vials, allowing sterile water to flow down into the Activase vial. Allow all the water to flow through. When you get to the very end, there may be, once it stops, there may be a very small amount, about a half a ml, ring in the sterile water vial. That is okay at that point. At this point, you can remove the transfer pin in the sterile water vial and discard those according to your protocols. At this point, you never want to shake Alteplase vial. At this point, you want to swirl it or I'll rock it back and forth to mix that gently. I'm going to emphasize do not shake, and then let that solution stand for several minutes to allow it to restitute, and also allow any large bubbles to dissipate. The resulting solution you have is 1 milligram per 1 ml. Prior administration, you're going to want to inspect that solution, inspect it for particulate matter and discoloration prior to administering it. Solution is generally colorless, but it can be up to a pale yellow color. At this point, you'll want to remove any quantity and excess that's best for the patient's dose. So insert a needle through the keyhole port. On the top of the vial, there's the center of the stopper, and there's also a mark off to the side. That's the keyhole port. And you insert a needle, you will insert it there, away from the puncture site. That was by the transfer device. And because that puncture site is there, do prime the syringe with air. Just put the syringe in and withdraw the excess. Don't prime that syringe and force air into the vial. Prepare the bolus. There's two options for preparing the bolus. The bolus is 10% of the total, or 0.09 milligram per kilogram. You can pull it from the white site on a infusion set, or you can remove from the vial. Like talked about before, insert the needle in the keyhole port away from the center of the stopper, and don't open that vial with any air. After withdrawn the bolus, you can insert your IV set through the center of the stopper. Important, use the same puncture site that you used with the transfer device. So go right through that same site. Use the hole that's already there, plastic hanger back, and hang the vial. At this point, prime the infusion site. You take the bolus you withdrew earlier and administer that over 1 minute. And make sure your pump or anything you need is ready to go before you do the vial, because we want to begin administering the remainder of the dose immediately after the bolus dose treatment. This kind of goes back to the short half-life of alteplase. A big delay between when you push the alteplase and when you actually, or push the bolus and start the remainder of the dose, your body can actually degrade a good chunk of that. So want to, as you push the bolus, go ahead and start the infusion. Ensure that the full treatment dose is delivered. The recommendation is to spike a small bag of saline. It's the same IV set you infuse the alteplase with, and continue to run at the same rate, just to clear the IV line and make sure the patient did get the entire dose of alteplase. All information, including help with dosing, is available on the Activace website in the Resource Center. One document I noticed that I really liked was the dosing and administration poster. Many of you likely have in your facility. It gives you a quick reference to check dosing, and also gives you step-by-step instructions for reconstituting and administering the alteplase. Since I used it all at this point.
So again, the question and answer session. If you would to ask a question, you may press star followed by the number 1. Please unmute your phone and record your name slowly and clearly when prompted. You're required to introduce your question. To cancel request, press star followed by the number 2. One more for the first question.
Now people are entering questions. Mike, thanks a lot for that great presentation. What I'd like you to address is, why is nitro not the best option for controlling blood pressure for stroke patients?
As far as I'm aware, it's not the best option because it is such a potent vasodilator that your risk for which does increase at that point.
Again, for participants to ask a question, please press star and then number 1. You're prompted to record your name. To withdraw a request, press star and then number 2. One more, we have one question queued up. One is I'll get the name. Question comes from the line of June Weissman. Your line is now open.
This is Lan Wiseman. I'm the stroke coordinator at CHI in Alexis and Bismarck. I had a question concerning the blood pressure guidelines. At one point, you said 185 over 100 is where we were supposed to keep them at, and then it was 185 over 110. Is that clearly noted in the new guidelines, or is that something that we kind of search a little bit more for?
I did try to note that when I was going through. I believe that 185 over 100 was a typo. As far as I'm aware, it's 185 over 110. I think that was a typo on my part. So the recommendations I remember were 185 over 110 before initiation, and then after it was 180 over 105.
Okay. All right. Thank you very much.
Yep, no problem.
Thank you, Ms. Mann. At this time, there are no further questions. Speakers, you may proceed.
Once again, Michael. Moving on here, it looks like we might go a little over our allotted time, so I'm hoping many of you can still stay on with us here. Next, we have Robin Whelan, hope I'm pronouncing that right, who is a respiratory therapist at the Dakota Medical Center. Robin, I'll let you go ahead and introduce yourself and then give your presentation.
Yes, I am a respiratory therapist in Hazen at Secaucus Medical Center. We are considered a CAW, and I've been doing this now for going on 12 years. So hopefully I have some good information to share with you at this point in time. One of the questions we've been asked notoriously is, how do we keep the two medications straight, and how do we keep our packet all together? We deal with stroke very far and few between in a rural setting. But when we do, everybody becomes very concerned and very heightened in making sure that we keep things correct. One of the things that you're looking at here in the slides is this is the front of our crash carts that we have in our trauma rooms in the ER. We have 4 of them. And you can see how they are clearly marked. One will say cardiac and the other one says stroke. When I look inside the actual cart, if you can advance me. Do you want me? There you go. You can see that when you look in the stroke drawer itself, it's clearly the label to the actual stroke kit always sits up, and it's always in a big gallon bag, so everything you need for that stroke patient is already gathered and put together for you. One of the things that we did in that kit was we made sure that every piece of the supply were in there, so once you open that kit, you don't have to go anywhere else. If we can go to the next slide, you can see the stuff that is actually in our kit. In our kit, we do have the Alteplase. We do have a dosing card that's in there. We have labetalol. We have nicardipine in there. We have syringes. We have needles in there. We have blunt needles, and we have 2.5 ml saline. So we can hang these drugs without having to leave the area where we started from, so nobody's confused with what has been placed there and what has been used and what hasn't been used. The other thing that we did was, because we run the 2 so close together, if you look at the next slide, you can see that our cardiac kit itself is where our actual T and kinase actually sits. And you can see they are clearly separated. We have been going through a lot of new staff lately, so we have found that this really helps them out when we say we're having a cardiac code or a stroke code. They know that they're clearly indicated in 2 different drawers. And they don't have to try to remember what is what. Every one of our providers will ask for either T and kinase, like that, or they will ask for the Alteplase itself. Nobody uses the acronyms here because it is a big thing for us. We get so caught up in our acronyms, we do have a tendency to talk quick, and we do have a tendency to not enunciate very clearly. If you can go more, we do have a stroke packet, and in this packet, in this envelope that you see here, we will put a patient's label sticker on the outside for transfer, but on the inside is all of the documents that we would need to be able to send you to Bismarck, or as well as do our debriefing that takes place here afterwards. Can you go just one more slide? Thank you. Inside there, we do have a fast triage kit that's in there, so if we're walking down the hall to meet the ambulance, we can do that and quickly decide to sidestep over to our CT scan. We also have the NIHSS scale that's in there. Ours is color-coded with the help from HandPen. On the bottom of there, it tells you what the different colors are representing for the different regions of the brain. We have our thrombolytic therapy inclusion-exclusion that sits in there. We have an stroke transit protocol that has been developed by state, so we do that to make sure that everything is what the next facility would be looking for. We have our dysphagia screen that's in there. We have our kinase, our Alteplase vital sign sheet, the neural sheet, so you can see when we go to the next facility where our vitals were before we left us here. We have blood pressure management, our stroke order sheets, everything sits in this kit so that we can put everything clearly together. We also threw a debriefing form in there, so when it was said and done and we transferred that patient, we can go back and say, what did we do well, what did we struggle with, what can we make better for the next group that has to come through and run the stroke code the next time. We're always looking to enhance our program as everybody else is, but this is how we have been able to find our weak points has been by putting that debriefing tool in there at the same time so we get it while it's fresh in our mind instead of 2 days later, oh, gee, I should have thought about this. So that pretty much is how we separate our 2 things out, and this is how we put our packet together. I hope it helps whoever else is needing to put their packets together, and if there's any questions for me, I can.
Once for participants to ask a question, you may press star and then 1. You will be prompted to record your name. To withdraw your request, press star and then number 2.
I'm in here once again, Jana here. Good job, Robin. I am very impressed with the work that you've done in your facility to help facilitate the administration of TPA in a timely fashion. And I like the debrief that you do with your teams shortly after the stroke code. I can see value in that. Also provide any follow-up with EMS if they bring you a stroke patient.
Yes, part of our debrief, and if they're not able to stay with us, we catch them the next day and try to get them, and then we also invite them all the time to our stroke and trauma meetings. So because sometimes they're so busy, they just can't be with us at that point in time, but we invite them there so that they can speak for themselves at the meetings as well, or learn from what we're trying to do with them, or educate us. Sometimes we're not aware of some of the things they encountered.
That's great. How often do you have those stroke and trauma meetings?
They're quarterly, yes. So what we did, instead of having another stroke meeting on top of everything else, we combined them so that our providers will deal with stroke, cardiac, and traumas all in one setting, so we can get them there. And we usually get more than we anticipate to show up because they're once a quarter.
Seems like a great model. And you do some case study sharing at those meetings?
Yeah.
Yeah.
Depending upon who's actually running the show at the time. If we have only a couple trauma things to go through, then stroke will come in and we'll talk about some cases if we've had any to report at that point in time. The spotlight on reporting them and debriefing the actual cases.
Thank you. We have one question that queued up. One moment, please, as I'll get the name. Question comes from the line of Doris Wigan. Your line is open.
I color-coded NIH form.
Got it from Hennepin themselves, and what they did with theirs was they enhanced theirs a little bit. If you would like, I can actually show it to you. It's not something that is really there. It's something they actually enhanced on their own. I certainly can share that with everybody.
Did?
Yeah, all it does in the color coding in this is it just helps them to come up with regions on where we are looking at this problem, and we have found that sometimes that helps us with tertiaries because the numbers aren't exceptionally high, but we can come back and say, but this is in the cerebral area, or I'm seeing these symptoms here, and it helps them come up with better decisions. So that would be okay. Jay, if I sent it to you, right? You can just email it out?
Exactly. That would be greatly appreciated.
I can not.
Thanks. At this time, no further questions. Speakers, you may proceed.
All right. Well, if there's additional questions, thanks to both Mike and Robin for presenting here this afternoon. Very helpful information. And thanks to all of you who joined as well. And we'll wrap up our call. If you have any questions, you all have my email address, so feel free to reach out to me at any time. Thanks.
Thank you.
And that concludes today's conference. Thank you, everyone, for participating. You may now disconnect.